Well, good afternoon, everyone. My name is Viviane Ugalde, and I'm a physical medicine and rehabilitation specialist, and I work in Bend, Oregon. I work at the Center for Orthopedic and Neurosurgical Care and Research, and I also am the medical inpatient rehab director for St. Charles Healthcare. And how I am involved in the concussion program is I'm the medical director for our Center Foundation, who's responsible in part with our community partners for funding athletic trainers in all the area high schools here in Bend, Sisters, and Lapine. I have had, I think, probably 25 to 30 years now of experience in treating people with traumatic brain injuries. And in the last 10 years, my practice has become more focused on mild brain injury and concussions, but I still see quite a few people with more serious injuries. And I work with Sue Hayes pretty extensively in a multidisciplinary clinic once a month here in Bend, and we'll talk a little bit more about that. But I'm looking forward to exchanging ideas with you guys, and we always like to hear from the education community because getting kids back to school is an important part of their completion of their rehab program for brain injury. What I'm going to discuss this afternoon is current protocols that we use in the Bend Lapine School District, and we have some data for the school district in terms of injuries and what happens to some of these kids. We're going to look and see how we compare to some of the studies that are reported in the literature across the country, and then just talk a little bit about what else we're doing. Oops, I'm sorry. Let me back out of this. I think you guys have probably heard about concussions a fair amount now. It's been out in the media quite a bit, but you can see on the slides here, if you have an opportunity to look at them a little bit later as well, that there's just some data that there's quite a few concussions, and it's probably an underestimate. We have, well, sorry, my computer is going a little bit crazy here. We have, all right. Hang on a second here. Yes, I do love technology. All right, let me try here again. Okay, so as we were saying, there's quite a few injuries that can occur. And well, maybe I'll just talk as this is scrolling forward. This is looking at blood flow and changes in metabolites. I am sorry. I don't know what is going on. It seems like whenever somebody chimes in, there's something happening. Hold on, let me just.
I wonder if it's sound activated.
Huh. Let me just, I'm just going to close this for just a second and reopen it and see if that'll fix that. I apologize.
We didn't test for that. It's okay.
And there's a, yeah, there's a key here that is activated by voice from my other program, so I think it accidentally got turned on. So yeah. Let me see if I can stay away from that one. Here we go. So lots of concussions, and a lot of them occur with sports, particularly the high contact sports like football, hockey, soccer, particularly for girls, is the #1 sport. And up to 20%, so 1 in 5 of our school-aged athletes will experience a concussion. So it's very common. The CDC definition for concussion has changed a bit, and we used to think of it as more of a metabolic and not a structural problem in the brain. And now that we have improved imaging, we're starting to see that we can actually see some changes in the white matter tracts in the brain. But basically, any injury the traumatic brain injury can occur from a bump or a blow or a jolt to the head, and it causes the brain to move back and forth inside the skull. And the other important part to remember is that you don't have to have a loss of consciousness to diagnose a concussion. In fact, it's pretty rare to have a full loss of consciousness. This slide here shows changes in the brain after a concussion. And if you look at that purple line below 100 there, you can see that that's representing brain blood flow, and that can be altered for greater than a week. In some people, it took 10 days in this particular study for that blood flow to resume to a normal level. So there's lots of changes metabolically that go on in the brain. And if you want to think of it, it's like your computer getting a virus and everything's running much more slowly. The brain with a concussion will act very similarly. There's lots of different types of manifestations of symptoms that come from concussions, and some people like to put them in different categories. The cognitive category is one that you'll often see where kids have difficulty remembering. They'll have difficulty organizing data. So executive functioning and memory are commonly impaired, as is processing speed. So you may ask them a question and they may take a minute or two to answer you because of that delayed processing speed. Vestibulo-ocular and visual changes can often be seen, and so these kids will oftentimes have trouble looking at screens. And with the change to iPads for a majority of our instruction in the Bend area, it's been a particular challenge to get kids back into the classroom with those particular materials. Anxiety and depression is another common area, and particularly if someone's had a previous injury. Previous history of anxiety or depression, that can oftentimes worsen with a concussion. They'll often have sleep disturbances, they'll have headaches. In fact, headaches are probably one of the more common things that I treat in my clinic after concussion. And for some people, that can be very disruptive because the headaches can become persistent and chronic, and it's difficult to concentrate and remember if you have a splitting headache every day, all day long. The second impact syndrome is, thankfully, doesn't occur very much anymore because of the laws that we've implemented in the state of Oregon. And that is that if someone is hit in the head, that they can't go back into play and have a second injury that can sometimes change the way blood flows in the brain and causes a massive vasodilation, a severe swelling, and that can be fatal. So we don't see this too often anymore because we've been getting better about identifying concussions. Here are some protocols and resources. We just updated the Bend LaPine School District concussion protocol, and I know Tammy Pike was a part of that group that helped with that. And we're in the process of looking at Sisters in Crook County and Culver and Madras as well. They're modeled off of the CDC website, and CBERT has some resources as well in terms of protocols. So we basically took from those areas to help mock that up. And then the Federation of High Schools has one, and there's also information about protocols and resources through the International Consensus, and you can see that publication down there. All you want to know about concussion, but we're afraid to ask, is available in that publication. So how do we handle concussions in the schools here? For high injury sports, we do a neurocognitive test that's computer-based, so that we can get a baseline. It's a little bit better picture of the student's memory abilities and processing speed. It's not a full neurocognitive battery that someone might get at a neuropsychologist's office, but it is helpful to get another picture of what's going on with that person. Because as many of you may know, just a regular physician's physical examination is not often sensitive enough to pick up the subtleties of cognitive changes that can happen after concussion. We have ATCs in all the area high schools here, and we've been making efforts to try to get them for middle school football as well. So those trained individuals are available for sideline evaluation, and that's an invaluable resource for the local high schools to help identify concussions and then help with appropriate treatment and referral. The student, if they're identified with a concussion, they're pulled from play and they're recommended to have cognitive and physical rest. We'll talk about some progressions of protocol there. That's changed a little bit in the last few years. We definitely don't want people staying in bed for weeks at a time. It's important for kids and adults, even with concussions, to start to move and return to some mental activities as tolerated, because there's studies to show that you actually have a worse prognosis and slower return if you don't do anything. School accommodations are also very important in that return to learn piece, and we'll go over some of the protocols that we use here. The athletes are assessed and they're determined to be released for a progressive return to play protocol once they are in school full-time without any need for accommodations, if they have no symptoms, if their neurocognitive tests have returned to baseline, and their balance tests have also returned to baseline. The SCAT-5 is what we use in our clinic, and our athletic trainers use this as well. And I believe I have a picture of this. No, I don't. But if you just Google that with that website, you'll see the full form there. And that's the type of questions that we'll ask for an assessment. These now are showing common symptoms that athletes and frankly anyone with a concussion will complain about, but headache is definitely one of the more common ones. There's typically a degree of some confusion or disorientation that goes along with that as well. One of the things that we've begun to recognize more fully in the last several years is vision testing, and the visual oculomotor screening test here looks at the way a student would move their eyes when they're looking at objects or moving quickly back and forth, glancing from one item to the next, or focusing something as it's coming closer to their nose, as you see that this athlete's doing. And then what do the eyes do and the vision do when you're moving your head or your body in space? And oftentimes these nerve pathways become disrupted in concussion, and they can contribute to a person having ongoing headaches and dizziness. And these symptoms are important to identify early and give the athlete and the student reassurance that things will get better, because it does give you a very disorienting feeling. And some people with a history of anxiety, if they have a set of these symptoms, it can be very, very anxiety provoking. And those two are often linked as well. In fact, I've had some people without any history of anxiety get severe anxiety with lots of the vestibulo-ocular symptoms. The balance error scoring system is another way that we assess a person. This is looking at your cerebellar and the vestibulo-ocular links to that cerebellar system for balance. And I believe I have a picture here. Here's the 6 positions that the child is put in. So they're standing with their feet together with the eyes closed for 20 seconds. Then they're balancing on their non-dominant leg for 20 seconds. And then the non-dominant leg behind in a tandem. I call it the slack line or the balance beam position. These are all done on the floor with their shoes off. And then we go to a 4-inch foam, Eric's foam mat, and it's much more challenging. And there are normals based on a kid's age that are available to see what they should be testing at. And of course, athletes should be even better than the average. So we have these athletic trainers available at school practices and games. We have physicians available at the high-risk sports. And then we have a walk-in clinic available Monday through Friday, where an athlete can come in to be assessed like an urgent. It works as like an urgent care clinic. We call it the Now Care Clinic here in Bend. So they're pulled from practice. They're given a sheet to say what to look for current symptom or for symptoms that you need to watch out for, and they're not allowed to return to play. And they're sent with this sheet to say, here are some of the symptoms that you need to look for, and when you might need to go to the emergency room if those symptoms are getting worse. Now, obviously, on the field, if a student has been knocked out, they have loss of consciousness, and they have these type of symptoms coming on fairly rapidly, they're going to be transported by an ambulance to the hospital right away. But sometimes these symptoms don't come on until later. They can develop later, and so that's important to recognize and to check for these, particularly in the first 24 hours when you're at risk for bleeding in the brain. And here we go. There's some more things to think about to go to the emergency room. The other thing that I think sometimes parents will be concerned about is CAT scans and the amount of radiation. These slides I borrowed from one of my medical students who was a big equestrian, and she had some pretty fun looking slides. But the bottom line is that you don't need to get a CAT scan necessarily. The changes in the brain are so subtle that they oftentimes are not picked up by the CAT scan. However, if you are concerned about bleeding on the brain or there's some developing neurological signs, then a CAT scan is very appropriate and needed to make that diagnosis of a subdural or an epidural hematoma bleeding on the brain. So now, who do we have here in Central Oregon that helps us with our concussion management team? Well, we have the athletic trainers that we've talked about on the field. The school nurses and school counselors are the important key member to helping the student return to learn. We have our ERs and urgent care and the Now Care Clinic to help with assessment immediately. And then our primary care physicians, some of the specialty care neuropsychologists are available as well. And then teachers and coaches are another important component of that team in that return to learn and return to play component of concussion management. So follow-up after the ATC sees them. We talked a little bit about maybe going to the ER immediately if there's some concerning things, and going and seeing other healthcare professionals for follow-up if there's not an immediate need for emergent care. What we do with our baseline impact testing, so we're coming to the neurocognitive piece. We do the computerized testing in the schools. The athletic trainers arrange them through the computer lab, and they're mandatory for the high-risk sports. And then we recommend them for several of the club sports, and they're available at the center for $15. I think Desert Orthopedics here in town also does them for a similar fee. We do these testing every 2 years in the high school age because of the changes in the brain. And in the middle school years, we would recommend it yearly because of the growth and development of the child. There are some limitations, and the OSAA has implemented the impact testing across the state. But if you don't have someone who is used to interpreting these appropriately, they can be misused. And so we always make a point of stating that this is a component of our concussion management program and return to learn and return to play, but not the sole test that would decide those things. And the balance error scoring system is an important test that we'll do. We did try to do some baselines, but that was not easy to implement. So now we just do them immediately after the injury and follow them. And oftentimes the balance error scoring system, the BESS test, will return to normal within 7 days. I find it very helpful in doing in front of a parent who's maybe not believing that the child has a concussion, and they'll see significant balance challenges for them. So it can be a helpful tool in that way as well. And if you have a student who you're not sure that they've had a concussion or not, we will do the neuropsychological testing with the impact. Now, coming to academic adjustments or accommodations following a concussion. This is one from OCAMP and ORCUS that we have used pretty extensively. There was an adaptation done by Mountain View High School counselor and school nurse with Sue Hayes, and I believe Sandra Marshall was involved with that as well. And so it looks a little bit different than the one that I have shown here on the screen, but a similar idea that there's definitely categories of accommodations depending on what the student is complaining the most of. And of course, the most common accommodation is no PE, but I've oftentimes adapted that a bit to say I don't want them doing any ball sports, but I would like them to walk, for instance, or perhaps use like a stationary cycle if that's available. Or I've even released them to do very light weightlifting, depending, because again, that return to activity piece can be important. The main thing is that you just don't want them doing any kind of contact sport or something where they can get hit in the head, because while they're still healing, that can be a challenge. and create more symptoms and delay their recovery if they have a secondary injury on top of their first injury. Other things that we commonly will say is let the student wear glasses, tinted glasses or sunglasses to deal with light sensitivity. There are some earbuds that actually allow the student to hear but dampen the noise. So if they have a lot of noise sensitivity, I've asked some of my students to get those. They're online and they are just $20. So hopefully most folks can afford that. And it's just called earbuds, EAR and then BUDZ. And if you just Google that, it should come up if you have any interest in that. And then, of course, I think probably the most common one that I will state is just to give extra time for homework and tests. Some of the student athletes and students that have concussions that are non-OSA sport related will have challenges with AP classes and IB classes and when to take SATs and ACTs and that sort of thing. And it's very important that the athlete and student does not take a standardized test soon after their concussion because they're going to do horrible. And so sometimes we've been able to get a reschedule or a refund for that student. The other thing that I think that I have seen in implementing these accommodations is that they work pretty well for a couple of weeks, but if you have a student that then is starting to have symptoms lasting beyond that, then it takes a little bit more coordination and intervention by both, I think, the medical staff and the school nurse and counselor. And sometimes it's not an easy fix because you want the student to be able to demonstrate that they've mastered the material that you have in your class, but at the same time, if you're trying to do every assignment and catch up, that extra cognitive stress on the brain can be tough for the student and also create quite a bit of anxiety. And I think that's a pretty common thing that I'll see is students worrying about getting behind. And then the other thing that I see is sometimes students who are already challenged or have challenges in the classroom and with their attendance and performance, getting a concussion, and then how do you accommodate for that when they were already performing poorly. So those are special challenges. I think that's what makes the multidisciplinary clinic that we run every third Friday of the month with Sue Hayes present to talk with the parents, talk with the student, find out what the families have already tried to do in intervening with the school nurse and the counselor, and see what we can figure out in terms of practical interventions and help. I think that Sue Hayes and Joe Devine last year, who went out to the schools for the folks that were really having challenges with getting back into the classroom, it was just instrumental in helping those students and their teachers understand a way to navigate through their rehabilitation and recovery. Anne Glang is a super smart gal. You guys probably already know her, and she has the Brain 101 program that she developed, and I know that OCamp has been interested in reviving that and updating the animation. So hopefully that will come into play. But this website that I have up here is really a great one for looking at academic accommodations and just reading a little bit more about that. This is from the Siebert website, and it just talks about a potential progression of mental activity after someone's had a concussion. And so you can see that day one, you're going to be resting. There are a couple studies out there now that show that resting beyond 3 days is really not beneficial. And when I'm talking about resting, I mean like a complete total rest, lying in bed, doing nothing. So I think this step protocol is appropriate. So step one might take 1 to 3 days, and then step two would maybe be 2 to 5 days, depending on how the recovery is going. For some students, that recovery may be quick and be completed within a few days in terms of their being able to tolerate mental activities and physical activities without aggravating any symptoms. So it's all very individual depending on the student. This is just, again, taken off of the Seabird side and just talking about some potential common academic accommodations. So who are the people who may get more prolonged symptoms? Is there a profile that we can figure up on these folks, or is it just case by case and there's no way to tell? Well, there's been several studies that have looked at that the younger the brain, the longer it'll take to heal. If you've had a history of prior concussion, that's definitely associated with a prolonged recovery. And then there's a symptom checklist that is a part of that SCAT-5 that has 22 symptoms that you can list. And there's a scale from 0 to 6 where you can rate how severe those symptoms are. And so that symptom severity score can go up to as high as 132. And they've found that scores that are 50 to 60 or higher are associated with a longer recovery. And that makes sense. The more severe symptoms may take longer to recover than milder symptoms. Headache and fatigue in the NHL were big time predictors of prolonged recovery. And then here we go. This is the symptom checklist of 126 items. If they had a score of 42.5 or greater, their symptoms lasted greater than a month. So a majority of concussions will clear within 7 to 10 days in terms of their obvious symptoms. Recovery time may be longer in children, and I say obvious symptoms in the sense that there may be some subtle things going on with brain recovery that we can't see, and so that's still a controversial point in terms of, is a person truly recovered from concussion prior to returning to contact sport? Persistent symptoms of greater than 10 days are reported in 10 to 15%. And if you have symptoms for more than 3 months, then you go on to be called a post-concussive syndrome. There's a little bit of a controversy in that, in the sense that I believe the official diagnosis would require positive loss of consciousness, but it's used, I think, more loosely for a clinical definition here. And so any child with symptoms greater than 3 months, we'll call it post-concussive syndrome. Here's just another slide talking about conditions that are associated with prolonged recovery, and one that I failed to mention. If you look at number 6 down there, there's certain pre-existing conditions. So if the child has a history of a headache or migraine, or a family history, particularly on the mother's side of migraine, that's a high risk for prolonged headaches. And ADHD and other learning disabilities are also associated with a longer recovery, and anxiety and depression. So how do we manage the symptoms? Those can be tricky. For headaches, we can use various medications. We also, in town here, have an acupuncturist who actually does acupressure. And he is, I think, a big boon to our community, because, as you can imagine, a lot of kids don't like the idea of needles. But someone doing massage over acupressure puncture points can give them some decent relief in their headaches. There's a lot of dizziness, neck pain, and vertigo that can be associated with concussion, and so we use our physical therapy and occupational therapy folks extensively. And then I don't know if I have, here for nausea and sleep disturbance, here are a few things that we would also use. For the nausea, that typically I don't treat with medications, but sometimes with even just ginger, like the ginger candies or the ginger tablets can help. We try to stay away from pharmacology if we can with kids, but sometimes, particularly with the headaches, we do need to dive into that to help with symptom management. And then for the psychological interventions, that can be super important and not to be missed. So we have some questionnaires that we have our students fill out to assess the degree of their depression and anxiety and how it's interfering with their daily function. One of the things that is not listed on the slide here is that we'll use our speech therapist pretty extensively for cognitive retraining, assessment, and developing some compensatory strategies, particularly for use in the classroom. So if you have a kid with a lot of executive functioning problems, they can't get organized, they can't prioritize, it's difficult for them to break things down to learn. The speech pathologist will help them understand the degree of their injury and then devise some ways to help them be more successful in the classroom. And so they're a part of our multidisciplinary team in that multidisciplinary clinic that I was mentioning. They're key for making those assessments and helping to get the kids going back into school. Physical rest, we talked about it not being a good idea to stay on the couch or in bed for 3 days, and we can mess up some of our autonomic nervous system responses if we don't get moving. So it's important to start moving. And so as a part of that multidisciplinary clinic, we have a physical therapist who will put the kids on a treadmill and start walking them and monitoring them for when their symptoms worsen, so that we can get an idea to give them an exercise prescription to keep their symptoms under control without aggravating it. So it's clear that there's some rest that's needed, but too much rest is no good. So that's another key component for someone who's having repetitive headaches, to identify if there is a component of that autonomic nervous system that's bringing those headaches on, and how to exercise your way through those. And this just describes the Buffalo concussion treadmill test that we use to help identify that. And you may have heard of that in other lectures, but we use this pretty extensively to help to give a person an exercise prescription. Helmets are always a common question that our athletes and parents will ask about. And the bottom line is that helmets help to prevent the bleeding on the brain, the subdural and epidural hematomas, and the skull fractures, but they don't prevent concussion. So we're still hoping that something will come up that might help, but right now we do not have a helmet to help with that. We talked a little bit earlier about return to play. So once the student athlete has all of those other areas recovered and doing well in school, then they typically have about a 5 to 7 day return to full activity. If the athlete begins to get any kind of symptoms as they're progressing through that a return to play progression, then you stop at that level and continue, and then challenge them again a few days later. And this is just in a tabular form, that same idea of advancing activities. This is the OSAA form that we'll fill out for students to return to play. Now, if you want to just talk briefly about what we've seen in our data collecting over the years. So there was a group of data from 2011-2013 that looked at the 5 area high schools at that time that we were recording, and there was 282 total concussions in 2 years, and there were 17 recurrent concussions in 14 athletes, giving us about a 6% recurrent concussion rate. So the interesting thing was that the time between concussions was about 9 months was the average. So oftentimes you'll hear in the literature that people will have their repeat concussions within 2 to 4 weeks after they return to play, and that's not what we've been seeing. There were a few people that did meet that criteria, but for most of our athletes anyway, in this area, the repeat concussions typically occurred between 9 to 12 months later. So it gives us a challenge in terms of how we counsel people with recurrent concussions and when they can return to play and if they should return to play. This is just a breakdown of where most of the concussions occurred just by school. And again, this is in that 2-year period. And you can see that there's a little bit of fluctuation, but football typically is the most common sport to be associated with concussions. And in sisters, soccer just happened to be the leader for those few years. Then we looked at it again between 2013 and 2016 academic years. We had 275. We had an additional high school that we had data that we were following. And we had 19 athletes with recurrent concussions. So a recurrence rate of about 6.5, so pretty similar to our previous time. And if we look at that compared to some of the literature of high school athletes, for instance, there was this article presented in 2012 where the recurrent rates for their high school athletes was 13.5 to 15%. And if you dive down into that article, you can see that some of the athletes returned when they were still symptomatic, so they weren't necessarily following their protocol exactly. We're very strict here that an athlete must have complete recovery of symptoms before they go into that return to play protocol and get back to play. So I think with the way that we're doing it, we're definitely capturing and preventing recurrent concussions. Whether we can get any better or not, it remains to be seen, depending on how our protocol morphs and changes over the years. And this is just another slide just saying, hey, in this particular data for 2013 to 2016, the interval between concussions was greater than 300 days. So again, how do we counsel these kids that have multiple concussions? And if you have an athlete that has a concussion in his freshman year of a football season and then comes back and wants to play, he's still at risk for another concussion. And we just haven't found a good identifier for those to help counsel those kids that may do that. And this just talks a little bit about some of the recommendations out there in the literature that if an athlete suffers 2 concussions in 1 year, they recommend taking 1 year off from the sport after the last concussion. And they say this is a conservative recommendation, but does that really make any sense if we see that it's usually repeat concussions in greater than 300 days? So a conundrum that we hope to solve maybe in the next few years as we get more and more data and understand recurrent concussions better. Just a brief summary of what are some other things that we're doing besides this concussion management program that I was talking about earlier. Well, one of the things that we do through the Center Foundation concussion program is that a big part of our mission is education. So every 2 to 3 months, we have a community concussion call, which is very similar to this. It's through the GoToMeeting app, and we try to review the latest literature or discuss or troubleshoot local issues. And it has a variety of providers on the call, and everyone is welcome. There's some information there on the screen if you want to join the call. And we've had people from as far as Klamath Falls and Medford to the south, and Burns and Hermiston join us. So we really appreciate everybody that participates in that call. We also have a concussion conference planning committee, and we organize national experts to come to our community and have a formal education program for providers and educators. And there's 3 of them that have occurred so far in the last 6 years. We also have the multidisciplinary concussion clinic that I was telling you about, and then I also do just a weekly just myself concussion clinic on Fridays, and so we do that. We also spend some time educating community coaches. I just gave a lecture yesterday to the Ski Patrol to help with their concussion education program. And then I talked a little bit about Sue Hayes and Joe Devine from HTESD, and I think they've really helped us tremendously in the return to learn component for our students, because there's a small subset of students that just do not get better in a timely manner. And so they help with discussing 504s and IEPs and implementing changes at the classroom level. We're hoping that we can continue to do this. This was a pilot study last year, and we did get a little bit of money to continue it this year. And Sue Hayes has been leading a group here in Central Oregon to talk about some sustainable funding for this service. Okay, so return to play protocols are more structured and when applied reduce recurrent concussion. As you can see from our data, looking back from 2011 to 2016, the recurrent concussion rates were 6 to 6.5%. And so basically that means that 94% of students, when they go through this protocol, will do well and not have a repeat concussion. We're still learning from our academic partners here in Central Oregon about return to learn protocols and how we can do that better. We definitely try to keep the pipeline open in terms of sharing information, and we're changing our protocols within the clinic. If a student who's not a student athlete comes in to be assessed for a concussion, we try to have them sign a release immediately so that we can communicate with the school nurse and the school counselor to keep them in the loop. The concussion protocols for the athletes have that release as a part of their athlete paperwork, but for kids that are outside of that realm, we've been trying to recognize that and develop protocols to improve communication between academics and the medical community. And then pooling of community resources improves concussion management. I was just at a meeting, our national meeting in Denver, and there was a group in Colorado that developed a community concussion hotline where there was a nurse that was hired to basically triage people with concussions to make sure that they got into the appropriate providers. So I talked a lot and I talked fast. Hopefully you guys could hear me and understand me. And I am happy to take any questions at this time.
Let's see. If you have any questions, go ahead and type them in the chat. And we'll give that a couple minutes. And if we don't get any, then we'll say goodbye. Here's one. How is Bend doing with enforcing Jenna's law with club sports?
I think what we've done is we've definitely made an effort to increase the education with the club sports. The Center Foundation actually is now partnering with the Timbers, which is the local club sports for soccer, and they have, I don't know, a phenomenal number of kids within their program. And so we actually have an ATC that's working with them to help identify concussions on that level. Like I said, we've also gone to like the ski patrol. We've gone to like the local indoor soccer gym to provide education. And we've been working with the Bend Parks and Rec, who does a lot of the Pee Wee football coaches and have done a lot of education with them as well. So I think we have definitely improved the educational level of the club sports. I think there's still a ways to go. We did chat with the hockey people a couple of years ago, but we haven't chatted with them recently, and it's probably a good idea to check in with them at least yearly.
On the Siebert end, if we hear about a club sport that is not enforcing Jenna's law, we'll look up the director's name and send information about Jenna's law off the website to them, because we believe that many of the club sports don't know what they're supposed to be doing. So there's a couple more questions. Yes, we will get a copy of the webinar to everybody. We will post a recording of this webinar on the Siebert website, and we also post PDFs of the PowerPoint, so that'll be available. Let's see, there's another one. Here's one for you, Viviane. How do you make sure that your local schools are conducting the impact baselines for the high incident sports?
And so the athletes, as a part of their athlete packet, have to get the baseline component done before they're checked off for their completed packet to play. And the athletic trainers are in the schools and monitoring that and making sure that all of the athletes get their baselines performed. Now, there are a couple that do fall through the cracks, but it's very rare. So the athletic trainers, that's one of their primary responsibilities, and they do a good job of making sure that those baselines are completed.
Okay, let's see. The next one is, do you see an increased incidence of post-concussed kids who go on to present with PTSD?
I think I see a fair number of them that have anxiety disorders. I have not seen PTSD in the traditional sense of, having nightmares and flashbacks and that sort of thing. I haven't seen that a whole lot. I do see that in kids that have been involved in motor vehicle accidents, but not typically like the sports injuries or the playground injuries that we see.
Okay, next one is it school-based or community-based SLPs who are most involved with implementing classroom strategies and accommodations during return to learn?
That's a really good question. It's my understanding that the school-based speech therapists are pretty overwhelmed with some of the kids that have, developmental delays or other issues. And so run-of-the-mill concussions, they just don't have the capacity to treat those. So we do use the community-based speech therapists pretty extensively. And, that's been a little bit of a challenge here in Bend and Redmond because we've been a little short-staffed, but they are really instrumental, I think, in making those assessments. Now, the neuropsychologists, if you have some in your community, they may be another good resource if you don't have a speech pathologist, that they could do more intensive cognitive assessments and then help to develop some strategies as well. So I think those two groups are important to think about, and if you see a kid struggling cognitively.
Thank you. One last question is, have you considered including a school RN in the multidisciplinary committee along with the SLP, PT, and MD?
I think that would be fantastic if they could come. I think the reality is that they are pretty time pressured, and in any given multidisciplinary clinic, we might have kids from 6 or 7 different schools. So I don't know if it's practical, but we do try to get the folks to sign off on that release of information so that we can share our clinical notes with the school nurses. And I have taken calls from school nurses if they had questions about specific students. So we try to keep the lines of communication open. And I would love it if we could have the school nurses. I just don't know how practical it is for a community of our size.
And I would say, from what I know about the other communities around Oregon, that's a similar difficulty to get a school nurse. But if any of you know somebody who would like to do that, everybody's open to, I'm speaking for Viviane, but open to having a school nurse join. And we have a consortium in Eugene as well, and we would be open to having a school nurse join us as well.
Yeah, I agree. If they had the time, we would love it.
Mm-hmm. Absolutely. Okay. Last call for questions. Okay. On that note, thank you so much, Viviane. We really appreciated it. And everybody, just look out for this being posted on the website and be able to share with anybody who might find this valuable.
Thanks, everyone. Have a nice afternoon.